Okay, Jacob, you're 19 years old.
Yes.
And you're a student here at the university.
Yes.
And Jacob is kind of a very special case because he had a bilateral OCD, osteochondritis dissecans, on the medial femoral condyle. And, of course, as an adult, to have an OCD lesion that still hasn't healed is somewhat negative. A lot of times we end up doing an ACI or a Carticel for that. But fortunately, Tim, he still had the cartilage cap. And he had a prior internal fixation of both with a single so-called absorbable screw. And my one recommendation to the orthopedic surgeon is don't use the absorbable screw because it never absorbs an articular cartilage. And unfortunately, if you really want to get good fixation to get these to heal, we have to use a metallic screw, and one or two, and that gives us firm fixation. And so on this one, we went in and turned down the lesion, took off the cartilage on the back side, and reestablished a bone-to-bone contact, used the internal fixation screw that we then had to remove in 6 weeks. And you had the difficult job that for 6 weeks, if you have a screw in place, you can't have them putting weight bearing on it because it may have the potential to damage the joint. And just yesterday, we went in and arthroscopically did the same procedure for this. And there was a large fragment, took the back side off, turned it down like a flap, took the scar tissue. There's a considerable amount of scar tissue that we had to take out. So we did get good bone-to-bone apposition. And he has two small fragment screws. And we did get good fixation. I think we're going to be able to get these to heal. Now I'm going to compliment you because make a tight muscle. He's got a really good muscle, and you guys worked very hard after I took the screw out.
Right. In the early phase he did, and then we were trying to fit in his rehab in and amongst his attendance to the University of Cincinnati, and so we reached a point where his strength was far enough along, his schedule changed, and he's been really doing a lot of walking. If you've ever been on the University of Cincinnati's campus, somewhat
a lot of hills.
So, you know, his walking and some light exercise has done a good job of bringing back his left side.
He's done very good. So we have the same problem here that I'm going to say to you that he can do motion with distraction. So we want to keep the motion, but we can't have any weight bearing. And we want that 1,000 times a day. Make a quad, and then so make it go tighter, make it go tighter, tighter. So why don't you go over what program you have him on to keep some semblance of quad in the first 6 weeks?
Right. Well, he would be required again, and you can kind of see he's starting to pick that muscle, starting to kick in. A lot of it is just a proprioceptive feedback. So we would look at using electrical stimulation to provide a co-contraction. We would be looking at recruiting control from his opposite side and doing his isometrics alternating as well as simultaneous. We can initiate a straight leg raise program, but the key there again is making sure that they're engaging their quadriceps so that it's strictly not a hip exercise, but we are able to engage his quadriceps. Core control will be important too. As far as his hip exercises go, the electrical stimulation at least 6 times per day. But in terms of you know, a PRE program, we're going to have to wait at least 6 weeks because we need to create a little bit of a distraction with his range of motion without creating a lot of shear across his femoral condyle.
That's good. So well, you did a great job with this. And then he knows that when we take those screws out, and that'll be a simple procedure, simple arthroscopic procedure, we should be able to do that arthroscopically and remove the 2 screws. And at that time then, we probably need another 6 weeks before we're really going to let you do anything strenuous, just to give that osteochondral fragment every chance to heal. But then at about the 12th week, that's either healed or it's not healed. And we're going to you know, we still have to protect the joint against real strenuous lunges and strenuous strength exercises. But you'll have plenty of exercises you can put him on, and hip, calf, and knee to get that muscle strength back.
Right. I mean, we would almost use kind of the osteoarthritis program and precautions that we use with some of the older patients and apply those principles here as far as his muscle strengthening. His cardiovascular training, we'll look at using non-impact loading activities, so things like swimming, aquatics, deep water program, some stationary cycling. I would probably be a little bit more protective of the elliptical, at least initially, but again, that allows us a non-impact loading activity in a short arc of motion, letting him move back into a closed chain program with his wall sits, terminal knee extension, to again look at activating his quadriceps as well as his hamstrings and lower extremity. A lot of gait retraining, resistance activities such as cup walking, the orange band walking, to work on his hip control so that we control then the pathway that his femur takes, so he's not getting a lot of internal and external rotation, excessive motion, as well as making sure that we're getting his quadriceps to activate in mid-stance. So that first 6 weeks of protecting the joint, emphasizing early distracted motion, early muscle control, second 6 weeks of normalizing his gait, establishing full motion, pain and swelling control, and then after that 12-week mark to really look at then a gradual progression with his strength program.
And I think from my standpoint, again, to emphasize that we want to start these exercises within 24 hours of surgery. And we see this occasionally where for some reason we don't have an opportunity to start until 1 week after surgery, and it's my opinion that's just too late. And they just lose too much muscle mass in that first week, and I guess you'd agree with that.
Yeah, I think so. I think the other thing is that there's a little bit of a trade-off. I mean, we really have to keep him elevated so that we control pain and swelling. So if we can control the swelling, that certainly decreases then the swelling or fluid inhibition, that knee effusion inhibition to the quadriceps.
And he's nice and dry now.
And so we want that, the exercise, but at the same time then we want him to just kind of cool his jets for a week, get off of it, get it elevated, push the ice compression elevation so that we can do the specific things for his muscle.
Good. How do you feel about all that?
Feel good.
Good. Great. Thank you.